Hello, okay. As you can hear, we are recording this meeting for everybody to be able to see later. Welcome to the CVCA February Symposium on Integrative Treatment of Complex Trauma for Children. This is one of a series of 2 symposiums that will be presented by Dr. Cheryl Lanktree. Access to the slides are available in your chat for you to review now as well as later. There is also supporting documentation, including a page that will be used during our breakout session in your chat. Please take a few moments to go ahead and take a look at those while we're waiting for guests to arrive. A follow-up email will be sent to all participants within 2 days. The symposium, again, will be recorded and posted both on the CVCA website, as well as posted on our YouTube channel. Those links will also be provided. A little bit about our speaker. Cheryl Lanktree is a licensed clinical psychologist in private practice and a research assistant professor in the Department of Psychiatry and Behavioral Sciences at the Keck School of Medicine at the University of Southern California. She is center director and previously project director for the COPI of the University of Southern California Adolescent Trauma Training Center. She is the developer of Integrative Treatment of Complex Trauma for Children, ITC, which we'll be learning about today. She literally wrote the book, and co-developer of Integrative Treatment of Complex Trauma in Adolescents, which we'll be learning about next month. She also consults with the Institute for Adolescent Trauma Training and Treatment at Briere University. I'm going to go ahead at this moment and turn it over to Cheryl. If you'll just give us a moment to switch slides. Again, thank you so much for coming and welcome to this year's first CVCA Symposium. Cheryl.
I have to wait for you to end your screen sharing, Dawn.
Yeah, there we go.
Perfect. And then Cheryl, you should be good to go. And then Dawn, if you can put the slides in the chat for people that came in a little late, they are not able to see them. All right, Cheryl, we can see your screen.
Great. Perfect. Good morning. Happy day after Super Bowl and day before Valentine's Day. We're sandwiched in between 2 events here, and hopefully you will find this presentation today, which is meant to really be an introduction to the treatment model, integrative treatment of complex trauma for children. If there are any difficulties at all with people seeing the slides or hearing me speak, just put your comments into the chat box. We have lots of support today to make sure that you're all able to access the materials. In addition, we're going to have a Q&A at the end of the presentation, but I would invite you along the way, if you have pressing questions or comments, to enter into, add them into the chat box, and then we will address them at the end. We have a fair amount of material to cover. I would like to say that I hope you leave this session with some practical tools. You have the slides that we will be covering today, but I'm not going to go into every slide in detail in the interest of time, and really have more time to utilize some of the practical tools that are available with ITCT-C. Okay, and this presentation is based on the book co-authored by myself and John Briere, Treating Complex Trauma in Children and Families, published by Sage. And so that if you would like to delve more into this evidence-based treatment model for complex trauma, that would be your resource. But there are also some references at the end of this session that I'll mention and that will be in your slides as well. So to begin with, what is complex trauma in children? It involves typically multiple exposures to multiple types of traumatic events, simultaneously and sequentially. Early and later onset, usually ongoing and of an interpersonal nature. So what I mean by that is you're looking at, for each individual child that you are evaluating or you are providing treatment services to, you're looking at their individual situation. How long has the traumatic environment been there for them? Are they in a safe environment or an unsafe environment? Are they being cared for by consistently empathically attuned caregivers, or have they never experienced that? In addition to all these types of abuse and neglect that we see in kids who then exhibit behaviors consistent with complex trauma. So including emotional abuse and neglect, which is often overlooked, but as you will see as we proceed through the material today, disengaged parenting or caregivers who are inconsistently available to the child are going to be as traumatizing, if not more traumatizing, according to newer research that we're doing, including a study that was recently published by John Briere and colleagues. The disengaged parenting or acts of omission can be as damaging as acts of commission, which include abusing the child emotionally, verbally, being neglectful, child sexual abuse and exploitation, of course, physical abuse, witnessing intimate partner violence, peer or gang assault, community violence. That was particularly prevalent in the community, Long Beach, California. Some of you may be familiar with that urban environment where ITCT-C was first developed. We had situations where, say, in the event of a house fire, the fire department would not go out unless accompanied by the police. So our model was developed in that kind of an environment, but has been utilized and distributed and implemented across the country in urban and rural environments. I know some of you are from urban environments and some of you are from rural environments. So hopefully you'll find this material relevant. Traumatic loss, also a big area, trauma associated with immigration, historical trauma, of course, discrimination, racism, serious mental illness or injury can also contribute to complex trauma, and parental substance abuse. With all of these exposures that may begin very early on in a child's life, concomitant with those exposures, we have insecure attachment with primary caretaker as being also very relevant. Oops. Okay, sorry about that. So we're talking about early onset, repetitive exposures in the absence of safety and support, relational aspects of characteristics of the trauma are going to be more traumatizing than, say, it's a situation where the violence is random, or it's witnessing a shooting of a stranger, or we had a case in Long Beach where a young adolescent girl was walking along the street with her friends going to school, and a drive-by shooting occurred, and she had injuries to her arm, which then affected her ability to play basketball was very traumatic, obviously, and it was sudden. It was a single life-threatening event that would qualify as an event that could cause PTSD, could meet DSM-5 criteria, and in fact, I think it did for her. However, her trauma was mitigated by the fact that her family was very supportive and the assailant was unknown to her. Also, the support that follows or is subsequent to a traumatic exposure, the extent to which a child is feeling supported, is also very crucial to the impacts that may develop for that particular child. So you want to know how the child was functioning beforehand when the incident occurred, how close the relationship was with the person who hurt them, and then the extent to which they're supported afterwards. So acts of commission, as I mentioned, sexual, physical, and also psychological, emotional acts of commission need to be assessed and considered. Acts of omission, which include neglect, non-support, disengagement, re-victimization. Re-victimization meaning that if a child is not accessing services soon after the onset of the trauma, and that is often the case, especially with our older school-age child, say a 12-year-old who has had 10 years or more of these types of trauma exposures, but it really doesn't come to light until they have a particularly vigilant school counselor who notices bruises or notices that they have become very withdrawn recently. And then the trauma is identified and services are received. We know that assessment can prevent further re-victimization, and certainly treatment can also do that. So as much as possible, we want to be able to provide early interventions. Trauma intensifiers. Okay, so again, this bears repeating. Early onset for children who have experienced pre-verbal exposures, say neglect or physical abuse or sexual abuse, pre-verbally in the preschool years. Language is typically acquired for most kids around 3, but it can be, younger than that or older. But if you have a situation where a child has been exposed to traumatic experiences early on, then they're not verbally encoded. And you may have to infer those experiences from their behaviors, which are, say, triggered responses to situations, responses that are much larger than the particular situation might warrant. That gives us an indication, or at least, let's say it's a hypothesis that we want to test, that they may have experienced early pre-verbal or implicit abuse. And the extended frequent exposure, often for these kids, their exposures are not only within the home, but maybe they're also being bullied at school. Maybe they're also witnessing community violence, or they have been subjected to school violence. For a lot of these kids with complex trauma, it's very ubiquitous, and they really don't have a sense of safety except perhaps with you in the therapy room, or if you're providing school-based services, when you conduct that group that they attend, that feels like their safe place. And the relational context, as I mentioned, this is a critical point because it's the context whereby they have been traumatized. So therefore, the context that occurs within therapy, whether it's individual, group, or family therapy, is also going to be relational. And that's how the healing can occur and the recovery can occur because of the work that we do that is so interpersonal. Social marginalization also compounds trauma and can be a form of trauma in and of itself. So poverty, kids who don't have access to resources may be living in unsafe circumstances. These are situations that in and of themselves can be factors contributing to complex trauma. Fear of deportation, ITCT, both the child version, which we are talking about today, and the adolescent version, which we'll be talking about down the road. Both versions have been used in short-term shelters, Texas, Arizona, California, New Mexico, I believe, and these are, shelters where children are placed when they are unaccompanied minors coming in from Mexico, Central America. They're placed there until they're placed with relatives or in foster homes, carrying so much trauma from their home country, but also trauma incurred, witnessing violence, experiencing violence in transit while they're traveling into the US. And then, of course, as we know, in the last 6 years, this has really come to light, the extent to which these kids are also traumatized once they enter the US. And we were able to do a lot of training with therapists in these shelters who were seeing highly traumatized kids until the administration changed in 2016. And then there has been some sort of resuming of those services, but still not nearly enough. Social discrimination, race, ethnicity, discrimination, sexual orientation, LGBTQ kids, trans kids, or kids who are thinking about being non-binary or wanting to be a different gender. These kids are also at higher risk for being traumatized, being discriminated against, and this contributes also to complex trauma. We know that 22% of children in the US live below the federal poverty line. These statistics actually came from research prior to COVID, prior to the pandemic. And now we know that the numbers actually are higher than that. Child poverty rates, though, are highest among Black, Latinx, and American Indian children. And the trauma rates for marginalized children are also quite high. Now, we know this to be true. And again, these statistics are based on data that has been collected pre-pandemic, but also are influenced by underreporting. So I think even though these numbers are high, we can assume that they're even much higher. That up to 50% of those in child welfare, 60 to 90% of those in juvenile justice, up to 91% of those in high crime neighborhoods have been traumatized, 91% of those in the community mental health system. We found in studies that we have done at USC that when you actually ask kids, what a concept, right? You use direct inquiry and you ask them rather than expecting them to spontaneously disclose. That in the case of sexual abuse, spontaneous reporting was about 6.9%. Then clinicians were trained in very systematic, clinically astute ways to evaluate for sexual abuse. Then it went up to almost 32%. But within the girls, and this was in an outpatient clinic at USC where I was the training child psychologist for pre-doc interns, social work interns, psychiatry residents, and other therapists. We found that 1 in 2 of the girls reported sexual abuse. So these rates are going to be higher when you create that safe environment whereby kids are invited to talk about their exposures. If they're in crisis, they may be truly shut down, or alternatively, they are just all over the map talking about all the things that they have experienced. And certainly in short-term shelters, we experience that. Low access to treatment also has to be addressed. Our center, the USC Adolescent Trauma Training Center, was funded for 10 years by SAMHSA, Substance Abuse Mental Health Services Administration. Prior to that, in Long Beach, in collaboration with USC, and even prior to that, we were funded. And that's how we were able to develop integrative treatment of complex trauma and then test it out with a treatment outcome study that you'll hear about in a minute. But I just want to really stress and emphasize the importance of how federal funding and state funding have really contributed, and foundation funding for that matter, have really contributed to the development of programs across the country. And in California alone, we have lots of centers currently that are being funded by SAMHSA that are a part of the National Child Traumatic Stress Network. Currently, our center is funded through USC, and but we also provide trainings, and which I will talk about at the end in terms of resources that are available. But I'm mentioning all of that to direct you to the NCTSN website, where you'll find a lot of resources. And the intention with the network that was first developed in 2001, and I had the great honor of being a part of it from the beginning in 2001, shortly after 9/11, although plans were in place even prior to 9/11 for this network. And now it's huge. We have hundreds of sites across the country. So we have really, over the past 20 years, with this kind of funding and with this initiative, have really addressed the issue of access to services and the standard of care. It's a dual mission, and other funding sources have also contributed to this. There, in fact, is now a request for proposals that was currently, that was released in the past 2 weeks, and with a deadline in March. So I would invite you, and if you want more material about that, you can either contact Dawn or the NCTSN website itself around those proposals that are being invited for treatment centers. So although trauma, especially in the context of social deprivation, is a major source of psychological disturbance, we still work very hard to increase access to services, because again, we know that the majority of children who actually are in need of mental health services do not receive them. As compared to white children, in particular, racial minority children are less than half as likely to receive mental health services. And 85% of children and youth in need of mental health services in the child welfare system do not receive them. We're working against these numbers, but this is what we have available at this time. So the outcomes that we are going to be addressing with our treatment interventions include anxiety and depression, cognitive distortions, insecure attachment, relational issues that I've already mentioned, post-traumatic stress, but we go well beyond post-traumatic stress with ITCT. So I want to make that point that yes, a lot of treatment models out there that are EBTs, evidence-based treatment models, do address trauma, but sometimes they stop at post-traumatic stress, as opposed to also looking at dissociation, interpersonal problems, affect dysregulation, developmental delays. So these are all areas that ITCT addresses. And to continue, we have a lot of outcomes that we see in our kiddos. Self-injurious behavior, suicidality. I have seen those behaviors in children as young as 3 or 4. So we can't rule that out just because a child is not disclosing that they're suicidal. And we have different ways of assessing that are less reliant on verbal assessment. Identity disturbance, sexual disturbance, meaning sexual reactivity, behavior where they are exhibiting triggered sexualized behavior towards other children, say in high states of anxiety, enuresis and caprices. I could tell you stories about clients that I've had where we had a rule that didn't occur within the therapy session. So, you're addressing these issues with the family system. The caregiver system might be within a foster family, but also the school environment, and also working as a team in your particular clinical situation. Somatization, headaches, stomach aches, which often, again, can be indicators of triggered behavior when a child is experiencing a high level of distress. School-related difficulties, of course, we know about, but sometimes teachers and counselors are they're identifying the behavior as problematic, but they're not considering the origins or the underlying reasons that could include traumatic experiences. Social withdrawal, conduct disturbance, these are all things that we all see in situations that we work in with the kids that are presenting with traumagenic impacts. So what are some of the issues in working with complex trauma in children? Play, expressive therapy is essential. I've encountered with colleagues who actually conduct, therapy sessions with traumatized children, and also people that I've supervised over the years, that there's a reticence to use play or expressive therapy, that they're not comfortable getting down on the floor and using puppets or using the tools that we have available for play therapy. And that needs to be addressed. If someone has more discomfort around that, then certainly their colleagues can help them with that. Trainings like this can be beneficial, in that you can consider ways in which you can facilitate nonverbal trauma processing, which may be necessary for those kids who are unable to really verbalize their experiences. Eliana Gale, if you're not familiar with her work, she has written a number of books on play therapy, family therapy within a play context. And certainly in our ITCT-C book, we talk a lot about interventions that involve play and collage work. I'll show you a slide with some tools shortly, but with cases actually talking about the process from assessment to identifying the target areas for interventions, and then utilizing play to facilitate the work with a particular child. The role of assessment: children, as I'm saying, may not be able to verbalize their traumatic experiences and related feelings. So this can be a challenging area, and we have some ideas and suggestions about assessment. Needing to involve the relevant caretakers and systems. Of course, children who are younger, who are not emancipated, are highly dependent on the people around them who are providing the care. And it's essential that we collaborate with schools, DCFS, anyone who is interacting with that child, of course, with the appropriate informed consent signed by the holder of the privilege in a particular situation. Given that we're talking about children under 12, typically that's going to be their legal guardian or parent who is the holder of the privilege who provides that consent. But in a foster care situation, and it's going to vary depending on the circumstances, but it could be the social worker that's also involved. As a director of programs in Child Advocacy Center locations, so I was clinical director at Stewart House in Santa Monica for 8 years, and then director in Long Beach of Miller Children's Abuse and Violence Intervention Center. We had forensic teams in both situations, and both on site and people who would come in do the forensic interview, and then refer for clinical services. So there was a lot of collaboration because team members were co-located in these places. We had medical exams also conducted in the same location. So when you have that, it makes it easier. And sometimes if you have a situation, say you're in an urban environment where there is less access, or it's the case that you're not seeing people on a regular basis, then more effort has to be put into these collaborative relationships. I was working in my private practice. I have a practice in Santa Monica where I was seeing kids of all ages, adults, adolescents. Now I'm focused more on adults because as we all know, working with kids involves all these systems, and it can be really challenging and time consuming in terms of all the collaboration that you do. But I worked very closely with the folks who were representing the child's case in dependency court, the ombudsperson who really facilitated some of the collaboration, the social worker who was assigned. And this was a child who was forced by the judge to have visitation with the alleged perpetrator who had sexually, physically, and emotionally abused her. And so you can imagine there was a lot of collaboration there, but also consideration to boundaries and not revealing, information about the therapy process that had to be kept confidential, while also reporting to the court what the child was disclosing as an advocate, basically as an expert and as her therapist. So treatment is prevention. We are able to prevent further trauma through our treatment interventions. Of course, if we have access to a child earlier on, then we have even more potential for prevention of subsequent trauma. The attachment relational interventions that I'll be talking about are crucial. Multi-generational trauma, as we know, with historical trauma, racial discrimination, the horrible experiences that families have for generations, that will also contribute to the trauma that a particular child is presenting with. And we need to think about safety issues for our youngsters. What are they experiencing within the home, and also in their external environment? Are they safe going to school? Are they safe in the school environment? I worked with a young adolescent who was sexually assaulted on 2 different occasions on the school campus. So we have to consider safety issues in all of these contexts. Early onset pre-verbal trauma I've talked about, where we have to infer from the behavior, from the triggered behavior and the attachment style, which I'll talk about as well today, what the child may have experienced. We may be collecting a lot of collateral information from the family, which also helps us to understand better what the child may have experienced. And misdiagnoses are common, and trauma may be overlooked, as I mentioned, such as a child who's having school-related difficulties, learning problems, or behavioral problems, but people are really not addressing the causes for those issues. Okay, so collaborations since 2012 include all these different agencies, school environments, children's advocacy centers, outpatient, hospital, residential, et cetera, throughout California, but also across the country. Masters in social work programs have had trainings on ITCT and implemented. We've collaborated with other centers in the NCTSN as far as developing curricula. And if you're interested in that material, you can also access that at the website. Juvenile Justice Commission, this is more for older kids, adolescents and young adults. ITCT has been implemented across the state of New Jersey. And of course, private practitioners are using ITCT. So what is integrative treatment of complex trauma? It was developed at a hospital-based outpatient clinic, children's advocacy center, also in the schools, and inpatient medical units in Long Beach, 2001 to 2009, and also in collaboration with the University of Southern California, and then continuing to expand ITCT for adolescents and young adults from 2012 to present time. It's an evidence-based treatment model with the reference being the citation in 2012, and it's included at the end of your slides. Also considered a best practices model for complex trauma treatment by the National Child Traumatic Stress Network since 2004. There are fact sheets and training guidelines also available at the website. And this is more or less how it was developed from the point of referral. It might be a consultation that's being provided, or the child is directly screened and an assessment is conducted, typically over the first 3 hours of direct face-to-face contact with the child and the relevant family system. It may be the case that the family is really in need of family therapy, or say a substance abuse residential treatment program for a caregiver. So that might involve then a community referral that might happen concurrently with the services that are also provided in the clinical setting. Forensic interview also contributed considerably to the referrals that we got for treatment. And then following the assessment phase, which would be subsequent to the initial referral and screening, then we would conduct school-based therapy. We were in elementary schools, middle schools, high schools, and alternative ed, or what were typically fondly referred to as storefront programs, where kids who had exhibited behavior that was problematic in the regular school environment were placed in these alternative short day, like 9 to 2, which 9 to 1 even, I think, kind of a school day in a setting like they were located in actual storefront locations, like in strip malls next to the Police Assistance League, so we were able to use the basketball court. We did a lot of outreach into the community as well. So we did presentations, trainings in preschool environments, in church settings, Boys and Girls Club, a lot of going out into the community as well to provide presentations and trainings that would also then generate referrals. So clinic-based therapy, hospital-based therapy, school-based, with all these modalities, individual, group, family, and so forth. Okay, so it's a multimodal, component-based, assessment-driven treatment model for complex trauma in children, adolescents, and their families, and used throughout the US. ITCT-C being used with children as young as 5, so basically school age once they start school, up to 12 years of age, and ITCT-A, adolescent version, used for 12 to 21-year-olds, focusing on culturally diverse and economic disparities in a range of settings, as I've mentioned. So moving right along so that we can get into the assessment piece and have some time to practice a bit. First, I want to just quickly mention the evidence base for ITCT. It was a treatment outcome study whereby we collected data at 3-month intervals using the trauma symptom checklist for children. 151 children and adolescents were involved. Mean age was almost 12, range being 8 to 17, 8 because the trauma symptom checklist for children that was being used, some of you may be familiar with the TSCC, at that time could only be used starting at age 8. So very culturally diverse sample, 48% Latinx, 25% Black, 14% non-Hispanic white, 13% Asian, 65% female, 35% male. More than half had a history of child sexual abuse, over a quarter physical abuse, 17% community violence, 31% traumatic loss, 31% intimate partner violence. We had more kids with sexual abuse histories because of the piece with the forensic interviews generating referrals. A lot of those kids referred for forensic interviews. The CAC part of our program had been sexually abused, or there was a suspicion of sexual abuse. So these percentages actually relate to disclosures, to reports, etc., of those forms of trauma. 62%, so the majority, had 2 or more types of trauma, which also is what we find in other complex trauma samples across the country, that the majority of kids have had multiple types of trauma. 14% had 4 or more traumas. Again, based on what kids were able to report and what collateral information we were able to gain. In the school-based context, environments where we were providing services, we had less access to background information. Families tended to be less involved than in the outpatient setting. So that also contributed to the data being influenced by how much, access you have to the history that a child has. And the majority of children were in treatment for 3 to 8 months, mean being 6 months. There may be questions later about how you adapt this to short-term settings, and ITCT is definitely being used and has been used in situations where you may only be able to provide treatment for, say, 12 weeks because of funding sources. But in our experience, the majority of kids with complex trauma are going to require much more than 12 weeks of treatment. And this just gives you a visual on the statistically significant effectiveness of ITCT using the trauma symptom checklist, the TSCC, for all of these subscales: anxiety, depression, anger, post-traumatic stress, dissociation, sexual concerns. If you're of a research mind, or you like, analyses, and you like to understand better treatment outcome studies, then I would refer you to the paper. You may actually have that in your packet, but if you don't, you can easily access it on the internet, and the referral is provided at the end. So we found that in all of these areas of complex trauma, there was significant improvement. And we also found that longer children were in treatment, there was more improvement. So if we had been able to do follow-up, we weren't able to do that, but we hopefully would find that these positive effects of treatment were sustained over time. So what are the core aspects of ITCT? First and foremost, safety within the therapy environment, as well as their home environment, is essential before a child is going to be able to really process their trauma. They're going to need to have safety, or a sense of safety, in the therapeutic relationship, but also feel a sense of safety as they open up and they're expressing distress and experiencing distress associated with the trauma experiences that they're describing. This can also contribute to behavior at home. How many times have you heard a parent or a caregiver saying, you know, she was okay until she started seeing you in therapy. And now all hell is breaking loose because she's defying me. She's not following, you know, that may mean that the child is truly activated by the experience of processing trauma and feeling empowered. So that means that that sense of safety actually can contribute to behaviors that might be problematic for the family. And that, again, is where psychoeducation is so important, and interventions with the family system are going to be so important. The centrality of the therapeutic relationship. This is a core aspect of ITCT, and the first two chapters, well, it may not be the first two chapters in the ITCT-C book, but it is in the ITCT-A guide, the case that safety and the therapeutic relationship are addressed first and foremost before you do trauma processing work. But you're going to return to those interventions that address safety and therapy and the therapeutic relationship as the child proceeds through therapy. It is the case that with longer term therapy being possible, that the underlying attachment insecurity is going to be more easily addressed. More about that shortly. Focus beyond post-traumatic stress, as I mentioned, attachment relationships, relational processing, very integral to ITCT, and an area that, again, other treatment models may not be addressing as much and typically do not address as much. Multiple modalities that I'll be able to mention with the cases that we talk about shortly. And customization, very crucial to ITCT. You assess individually the specific needs and resources for a particular child, considering their age, developmental functioning, gender, how they identify themselves as far as gender identity, their cultural background. And again, don't make assumptions in these areas. Invite the child to talk about how they identify themselves. Even a 5-year-old can do that. Trauma history, of course, is taken into consideration, and their affect regulation capacity, which is directly related to attachment security / insecurity, is also going to be a marker for letting us know their capacity to process trauma. We're focusing on the child's experience as well as the caretaker's experience, taking them where they are, support greater internal awareness within the client and the therapist always is mindful of their interventions. They're not making interpretations or dictating or being authoritarian or judgmental in their interventions or in their stance with the family. And sometimes that's a challenge when we're working with caretakers who are not so amenable to therapy and may have some difficulty by virtue of their own traumatic experiences, that and perhaps you don't share the same cultural background as them. And so they're really shut down and guarded. And it's going to be important to meet them where they are and facilitate opening up the channels of communication as much as possible. So trauma processing within this model is titrated. It's at the child and family's pace, involves cognitive and emotional trauma processing. Affect regulation training and distress reduction precedes typically trauma processing work. Advocacy and system intervention. It's not like, oh, that person over there deals with the case management issues, advocacy. No, I'm the therapist. I just do the trauma processing work. No, we do it all. As clinicians, we may be accessing financial resources, housing, back to school, clothing vouchers, taxi vouchers, transportation. We're really trying to provide them with access to resources that are going to support the very difficult work that they need to do in therapy. Caretaker and family interventions then are very much a part of ITCT. We have flexibility of the number of sessions, adaptations to different settings. And the key components, I'm not going to go through all of these. Today, we're talking more about attachment, relational processing, assessment, and affect regulation, distress reduction, thinking about mindfulness. But these are specific chapters in the book on ITCT-C and basically address all the core aspects that I've been talking about. Strategies for optimal engagement with families. Okay, so there is an initiative now within the network involving several of us who are complex trauma folks in looking at how we can engage and sustain interventions with children and families. So it's being spearheaded by Richard Kagan, who is also the developer of another complex trauma model, Real Life Heroes. And I won't have time to go into that today, but if there is interest, I can hook you up with the guide that is going to be available. And there's a research article also on strategies for engagement. But from our standpoint as ITCT clinicians, the environment needs to be oriented towards the child, very appropriate to the age and cultural background of the kids that you're seeing. You provide transportation, including taxi vouchers and bus tokens, essential resources, as I mentioned, holiday gift cards, food, clothing, back to school, etc. Advocacy and collaboration. Clinic hours are conducive to the families and school schedule. Culturally, racially diverse team, trained volunteers, so that, say, if you're doing a caretaker group or a parenting group, you have volunteers in the waiting room who are supervising the kids that are being brought into the clinic by the caretakers attending the group, so that they don't have to worry about transportation, they don't have to worry about babysitting. So these are really important resources, especially for the clients that we're working with who may have limited resources. Snacks and refreshments, food is always a big deal and definitely a winner for group sessions, for celebrations, graduations, from therapy, parenting classes. Having celebrations to mark occasions like holidays, multicultural events, these are all ways in which we are really providing that safety net for the kids and families we work with. And now just a few photos I want to share. This was from our waiting room in Long Beach, and no, we did not have oceanfront property, but since we had an environment with few windows, we really wanted to create an environment that was welcoming and that families could enjoy as much as this work, right, can be enjoyable. But we did have kids and families who were very reluctant to end therapy because of the nature of the support that they were getting from their therapist, but from the center overall. Some of our staff and volunteers, you can see a wall of artwork, obviously not with identifying information, but collages and so forth, that kids would stop and look at on the way into their session as a reminder that other kids would come to the same center for help and had similar experiences. The photo to the right is of a group of us at a multicultural event that we had, where we had ballet folklorico dancers, we had Pacific Islander dancers, drummers, art and food that represented various cultures of our community. And some of our clients said that it was actually one of the best experiences they had ever had with us, that, you know, was more fun than therapy, but they felt validated, they felt cared for, and these are all ways in which we can really facilitate engagement. So these are play therapy materials. As I mentioned earlier, when we're working with younger kids, even if we're feeling a little bit, shy or hesitant to get down on the floor and to, use these means to facilitate expression, it's going to be important, again, to be on the child's level. And, if they need to go under the furniture, we go under the furniture. And in fact, there's a video of a play therapy session with a child acting as a client who is highly dysregulated in a play therapy session that I'm conducting, that you can access at the NCTSN website. There's a whole set of webinars there that I'll describe later when we talk about resources. But in the therapy room, these are the materials that are recommended if you're having to move from office to office, or you're going to a school-based situation. Then you may have to take some of these materials with you. But you do want to have a lot of different things, from sand tray, puppets, Lego, paints, a wide range of resources, so that some kids are going to be more inclined to use books and they want to act out roles or voices reading the books together. Or maybe they're more active and they want to physically, this was actually an example of an intervention that a child created. He had reported sexual abuse by a teacher and was coming for therapy, was very dysregulated, and was a very physical kid. He loved physical activity. So he created a game whereby he, and I think this is in the book too, he created a target with concentric circles representing different body parts of the particular perpetrator, who was in fact prosecuted, which I think also contributed to this kid, my client's sense of validation. But he felt safe within the therapy environment. He felt supported by his family. So he was really able to do trauma processing work, and he was able to regulate his affect. But he would often create interventions. And the one with the target was, it was quite humorous, actually, because he wanted to do this every week, and he included his grandmother in sessions so that she and he would have a contest, and sometimes I would participate as well, with a cush ball, throwing the cush ball at the target that was placed on the door. And you can guess, what would be in the center of the target that was represented, with all the body parts represented with the circles. And we would get points each time we would hit a body part of the perpetrator. And then that contributed to him being able to do more trauma processing work that was explicit, where he could really create the coherent narrative of how he had been fondled by this teacher, and was able to really create his story from activity that was very physical and somewhat nonverbal to begin with. So it can ease that transition. Projective cards, such as O cards, that are available at Amazon and may be available elsewhere, but were developed a number of years ago by Raman, who was an artist. So they involve a deck of picture cards based on paintings that he did, and then word cards. And it's also been translated in a number of different languages. I was doing a training a few years ago, and a therapist in the training said, Oh, yeah. You know, I lived in Venezuela for a while, and she was bilingual, Spanish speaking, and she was using the cards in Venezuela. So very multicultural. The picture cards are very evocative, and it can be used in such a way that, again, a child can perhaps point to a card that is relevant and depicts what they have experienced, and tell a story using the cards in a projective manner. If we were all in the same room, I could do a demonstration, and we could you know, experience this directly. But I would definitely invite you to consider, you know, using tools like that, as well as very active you know, means of freeing up a child who is feeling dysregulated. Sometimes they can feel more calm, and that can actually facilitate breathing exercises that they might do. Which problem, behavior, symptom area to focus on first, and how do we increase self-capacities and positive self-esteem? Which therapeutic component do we focus on first? Do we do affect regulation? How do we identify what the child needs? Well, this is our segue into thinking about assessment. So how and what to assess in traumatized children, as we've been saying throughout: safety, how they might be endangering themselves, how they might feel unsafe in their environment. In many situations, neighborhoods, for kids that we were seeing in Long Beach, it wasn't safe for them to play outside, and they really had to be under close supervision if they were doing any physical activity outside their home. Trauma exposure, obviously, through the initial referral, the clinical interview, forensic interview, collaterals, documenting their post-traumatic play as you see it. These are all ways in which we can continue to assess the individual needs for a particular child. And then with symptom assessment, standardized measures are available at the NCTSN website. People use measures such as the UCLA post-traumatic stress index. They use CANS. They use less specific, less trauma specific measures such as Achenbach CVCA or Children's Depression Inventory, as well as trauma focused measures that you can see listed in the ITCT-C book, as well as the NCTSN website. And doing, as I mentioned, an initial clinical evaluation that may involve up to 3 hours. I wouldn't really recommend that the evaluation stage is longer than that, because it's going to be important to really convey to your child client that you are moving in and helping them to feel safer and helping them to process trauma early on. You're not holding back. You're not rapport building week after week. So expressive play and behavioral observations also can be very informative. And sometimes if you're in a situation, and we were in the 2 different centers that I directed where we provided on-site services, treatment services, we had one-way mirrors. So the supervisor could observe a therapy session, a team of clinicians could observe and provide feedback, all wonderful ways of really gaining a better understanding of what our kiddos are experiencing and what they need in treatment. Collateral information, I've mentioned. Drawings such as self-portraits, family drawing, kinetic family drawing, snapshot, showing the family also can be very revealing. I'm moving into, material that is going to then set us up for an exercise with an actual case. So bear with me as I, cover some of these tools. You might have questions along the way, but when you're in your breakout, hopefully we'll be able to do breakout sessions. You'll be able to discuss with each other how these tools are used. So when we use standardized measures, that gives us more information that perhaps is not available otherwise. In other words, I've had situations where I've used a standardized measure such as the trauma symptom checklist, but again, there are others that have been developed over the years, whereby a child reports that they are afraid of being killed. This was an actual situation. The child that I was working with, she was 8. She showed me the measure and she said, see, that's what I'm feeling. And she would not have been able to get there without having a question in a paper and pencil manner being, presented to her. So these standardized measures can give us more material, but I also want to let you know that I totally understand if you're in a situation where you don't have resources to be able to purchase standardized measures. I'll give you some other tools that can be used in the interest of collecting more information about that child's experience. And as we collect data, then that can also assist with funding and program sustainability. So now talking about our case, Anna is a biracial Latinx white 8-year-old girl referred for therapy by her school after disclosing sexual and physical abuse by an uncle. She is withdrawn at school, has difficulty making friends. She is functioning at grade level. So we have strengths and we have challenges mentioned here and trauma exposures. Anna was raised by grandmother while mother was in and out of the home due to substance abuse issues. Grandmother died a year ago. Anna reports nightmares, doesn't want to go to school, and cries many nights. She now lives with her mother, aunt, and 2 older cousins. Family reports ongoing conflict. Anna stated, my mom never pays attention to me. She gets mad a lot. Anna's mother says she was physically and sexually abused as a child. She divorced Anna's father, who was abusive and an alcoholic. If you have your handouts, there, then you'll be able to refer to the case, but I'll keep this up on the screen as we move into the practice. So the ATF is the assessment treatment flow chart for children, whereby we are able to identify treatment priorities. We rate on a scale of 1 to 4 the need or how significant a particular problem area might be for a given child, S being we're suspecting that it's a problem. It's completed at intake and at each 3-month or less period and used to identify treatment priorities. It can be inserted into the chart. So it's an assessment tool whereby you are able then, remember we had the question early on, how do you know where to start? When we have these very complex situations, we've got multiple trauma exposures. Well, this gives you a tool, and it's an essential part of ITCT-C as well as ITCT-A to rate for each problem area the extent to which it is a problem and warrants treatment. Now, having said that, make sure that you don't rate everything as a 4, because then you're back where you started, which is, I've got all these things to address. Okay, so now we're in the practice session. We're not too far behind. We're going to spend about 15 minutes on this. I want to be able to have enough time for interventions. So we're going to, and it looks like both Dawn and Sadie have their hands up.
Yes, unfortunately, we are having some severe technical difficulties today.
Okay.
And our breakout rooms are not working, just like we're not able to see everybody's lovely faces, which
Okay.
We have some options available to you. We can have people, we could do it as a big group. People can raise their hands and provide information. We can give them a little bit of a break here for a moment while we discuss it. Whatever you would like to do, Cheryl.
Okay. I'm just going to check the chat room now. Let's see.
In the
Okay.
Q&A, there was a
So
question.
yeah, let's maybe let's ask folks to enter into the chat room if they want to go ahead with discussion with a large group. We can do it that way. We can also, people can take a break as needed. We're going to be, moving quickly into interventions, which I know people want as far as practical, guidelines for intervening with complex trauma. So we may not be able to do as much with assessment right now. But I'm just, if people can suggest along the way what they're looking for, and I'll just carry on. How does that sound? And if you need to take a break, please do so, and come back as soon as possible, because we will be getting into the interventions in a few minutes. We're pivoting back to whoops. Do I have the? Okay, back to the ATF. Do folks have a copy of the ATF in their packet?
It is in the chat. I can post it right back up again as well.
Okay.
Let me switch this to other one.
And people are okay with a large group discussion or Q&A.
Okay.
So if people want to speak in the chat or raise their hands, I can allow them to talk.
Okay. So
I just posted ATF back in the chat stream.
great. So with the ATF, you have 20 problems listed. So if you can refer to that, and we'll go back to the case. So let's find the case. Okay, so back to Anna. Whoops. Oh, I'm sorry. There we go. Okay. So given all the traumatic losses and ways in which she has been traumatized, my screen is acting up. Okay. I'm just wondering if people maybe we could unmute. Sadie, can we unmute?
We can unmute if they raise their hand. Yep.
Okay. So, and you can see folks because I can't, right? You can see them if they raise their hand?
I believe so. We're going to give it a try.
Okay, great. So maybe if people could just make suggestions about what areas they would consider treatment priorities for Anna, given that she is presenting with, a range of traumatic experiences, acts of commission, as well as a traumatic loss, losing her grandmother. What you might think about, Anna telling you, my mom never pays attention to me. She gets mad a lot. How might you use this information then to, and it looks like Frances has her hand up.
Yes. Can you hear me?
Yes.
Okay,
Hi,
perfect.
Frances. Hi.
Hello. Hi. Thank you for the training. I'm really happy to be here. I think the first thing that comes to my mind is safety, especially if it's, she's disclosing sexual and physical abuse. Like my first question is like, does she still interact with that uncle? What is the home like? Does she have protective, caregivers that can sort of look at safety? So I look at safety, specifically environmental issues there.
So safety would be a high priority, and therefore that would be a chapter in the ITCT-C book that you would look at first, correct?
Yeah, I think so.
Yeah. Now, how does the mother enter into the situation, her environment? So you mentioned, yeah, we don't know if the uncle has access to her. What about in terms of interventions focused on safety within the home in other ways?
Yeah. Is that question for me or to the group?
Yeah, go ahead.
Okay.
Go
Okay.
for it. Sure.
I can't quite tell. I think, definitely like mom's involvement in terms of like safety planning, if the uncle is still kind of somewhat accessible or, is frequently interacting with the family, like really kind of making sure that mom understands sort of the situation. I would even explore if she's aware of this, right? So there's some like kind of confidentiality things kind of involved in this too. Like, how much does mom know to start with? And is she capable of sort of holding that with Anna? Because depending on where she's at, right? Just in terms of her own resources and her own trauma too. Usually what I've seen where we work at a domestic violence agency, like mom, usually parents hold their own trauma. It's rarely ever just, whoever we're seeing as the patient or the client. So I think, mom is a whole different assessment altogether. And then that will kind of inform the safety aspect of it, I guess. So it's almost like I actually don't know what the intervention is. If the intervention might be that I do an assessment with mom too.
Right. So, just starting with the assessment treatment flowchart and not even thinking about interventions just yet, the goal here is to be able to prioritize areas that need to be addressed. Now, if Anna, say, was a 17-year-old, then we might be cognizant of safety issues around the uncle and so forth. But if the caretaker is less amenable to being involved, we might go in a slower fashion, assessing for sure, as you have mentioned, their capacity, their interference due to trauma, et cetera. But with an 8-year-old, we need to be more direct, right? We need to really ensure that this child is safe in the home. And where there are potential safety issues, then confidentiality is less of a concern because we want to ensure that that child is safe. Say if Anna is telling you that she wants to die and she's thought about how she might hurt herself, that's a safety issue that would need to be addressed with the mom. We also have a couple other folks with their hands up, so we could thank you for that, Francis, very much. That was very much appreciated. Michelle and Teresina, I'm not sure if I'm pronouncing that correctly.
Yeah, I don't know if you can hear me.
Yep.
Yes.
Okay. Yeah, Teresina is right. You got it. I'm sorry, Michelle, did you want to go first?
No need to be polite. Just go for it. Teresina.
I was just thinking, given Anna's mom's past, right? And I think Francis was hitting on this a little bit. Is mom going to be emotionally sort of ready to deal with what's going to happen with Anna, right? Is mom going to be able to be present for that?
Sure.
Is one thing. And then, given Anna's ethnic background, is there a language barrier? Is there a cultural issue that we need to be aware of? Are there other kids in the house that may have had a similar sort of experience? So I guess that goes back to safety, but then, also I'm concerned because, you know, I see this a lot. I'm concerned about mom's own trauma, right? And
Right.
how is that going to come out during this healing process? And sometimes there's animosity, right? You know, mom never got help, and now here's Anna getting the help
Sure.
that she needs. And, you know, is that going to cause animosity between them? So those are things that just pop out right
Mhm.
away for me.
Yes, yes. And we will talk about caretaker interventions when we get into interventions. And typically, just to forewarn you that typically when I train on ITCT-C, we take 1 or 2 days for the training. So you're really getting kind of a thumbnail sketch, but I want you to have an opportunity to understand a little bit about the assessment treatment flowchart and how it can be used in conjunction also with the PIQTC, which is possible interview question topics, child version, which has 5 questions for each problem area. So say for safety, there are 5 different problems listed that you might be able to utilize to really understand, and the caretaker support, you know, area, to what extent caretaker support, safety, the problems that have been highlighted, have been mentioned, would be relevant for Anna. So PIQTC goes hand in hand with the assessment treatment flowchart for children, and then that also informs on the problems to components grid, which hopefully is also in your packet, whereby we have for each problem area that you're prioritizing then the relevant chapters with the specific intervention. So you can then take time on your own to explore, you know, what those interventions might be that are directly relevant to a particular child. Okay, Michelle, can we hear from you as well? And thank you, Teresina. Michelle, you still there?
Trying to unmute.
There
Is
you
it-
are.
Hi,
Hi.
yeah, I was looking at we do have the ATT-FC, and it's on a page that's page 42. You sent us that. So I was looking at it, I wondered it looks a little like the cans. And I wondered what you thought about, you know, the use of ATT-C compared to the cans.
Okay, so you're talking about the ATF-C. ATT-C is the name of our program. Or are you
Okay,
talking?
so it's
Yeah.
the book. Anyway, I'm looking at the sheet that you sent.
Okay, so you have hopefully the assessment treatment flowchart, which we've been talking about, which is a shorter version of a tool like the CANS, which goes into more detail about trauma exposures. The ATF is really meant to guide your treatment intervention specifically. So you're looking
Okay.
at problem areas, you're rating each problem area. Let's go ahead again. So on a scale of 1 to 4, or if you're not able to really determine to what extent, say, Anna has anger, maybe you suspect she has some anger and it might be a problem area down the road, but right now it's not evident. So that is how this tool is used. The CANS is like other assessment tools, which it's very comprehensive and it gets at symptoms as well. But this is meant to be a tool that really informs your treatment plan, if that makes sense, directly by prioritizing areas that you wish to target. Okay.
Okay.
Any other questions, comments, so that we can go on? Again, I understand that you may, be unsure about how the ATF can be used. I would suggest, looking at the materials that I'll reference at the end that describe the ATF more. There, you don't have to necessarily, access it through the book. There are other articles and materials that are also available that can explain it in more detail. Okay. Any other thoughts, comments, chat box?
There's the chat
Anything,
box is
Sadie, I
full.
need done? Yes?
Yeah, the chat box is full of potential, they've just typed out what they would look at first. So if you want to take a peek.
Oh, okay. Okay. So I'm not seeing in the chat box.
Let's see.
Oh, here we go. Okay. Now I see it. All right. All right. Well, I could do a demonstration if we were all in the same room and we could have, an easier discussion. We're trying to do a demonstration through this discussion, and potentially in the adolescent version of the training, when I do that, perhaps we'll have it set up so that we have breakout sessions and people can do their own demonstration of how to use it. Okay, so Celine is suggesting maybe focus initially on nightmares and not wanting to go to school. So again, I understand you're all using your clinical acumen and your experience based on this case to identify what areas, you would focus on. But again, I'm returning to the ATF and directing your attention to that. So that might be considered under post-traumatic stress, right? And that might then be considered if you evaluate it further and it turns out you're getting re-experiencing, you're getting avoidance, maybe use the TSCC or another measure where you get a high score of post-traumatic stress, then that would be an area to intervene with. Okay, psychoeducation regarding mom's abuse. So again, linking up these ideas to the ATF is what we're attempting to do right now. Okay, so someone is asking about the title of the book. It's in your slides at the beginning and at the end. The reference is there, and we can also include it in the chat box. Yelitsa is saying, I also believe the caretaker support issue is also priority. Since she lost her grandma and disclosed, her mother never pays attention to her. Yeah, so this might then be identified as attachment insecurity, which is number 11. And you might rate that as a 4. Okay. Tell the girl that she is so brave and make a CPS report. CPS report if you have new disclosures. Sometimes we're not sure when a disclosure is made, if it's new, and that's when we check it out with a social worker. If there's an open case, then we have someone assigned to us that we can share that information with. Again, information that is suggesting the child is at risk vis-a-vis safety is going to need to be reported. Right, Rosa. She's saying I'd assess for suicidality and self-injurious behaviors. Thoughts for Anna, do post-traumatic symptoms and screen for depressive anxiety as well. So those might be, in addition to safety, you might also categorize suicidality, self-injurious behavior. Assessing that further, that might also be a high priority for treatment.
We have 2 hands up right now.
Okay, let's hear from them. And then I'm sorry, but we're going to have to move on to the interventions. Yeah, so, but I don't want to ignore folks, and I'll definitely take a look if we have a chance at the end to look at within the Q&A time, the chat box. So those folks that have their hands up, we want to reward your initiative and your assertiveness. Okay, who do we have? We have Michael, and it looks like a sleeping puppy. Oh my goodness, what a great photo. Okay, Michael.
Hi, Cheryl. I had a question. So I'm looking at treatment priority, and there's a lot of questions about caretaker support when I read it. There's some things that seem clear. Mom's had a history of drug use before. She has her own issues with family trauma. So how has that changed how she's supporting her kids? But yeah, some things are less clear. So I guess what I was trying to ask is it possible to have a numbered system for treatment priority where I feel like support issues maybe number 4 for safety reasons and for reducing trauma from incoming, but also a suspected. So can we be circling that S and also a 4 at the same time?
Oh boy. So all the years that we've been talking about these tools, I don't think I've ever had that question. That's interesting. A 4 and an S at the same time. Yeah, I mean, this is not, a statistically supported standardized measure, like some of the standardized measures that we have available for assessment purposes. This is meant as a tool that is going to guide your treatment approach with the client. Again, revisiting the ATF at 3-month intervals. So it may be at intake, you're, in a quandary between 4 and an S. But in 3 months, when you do it again, and you're involving the caretaker perhaps in discussing what they feel their treatment priorities are going to be. This is the other thing that you take into consideration. With younger kids, like a 5-year-old, not so much, right? But say with a 12-year-old, especially as you develop a stronger therapeutic relationship, you might invite their input as well. With this caretaker, you might you might want to, since you're in this quandary of a 4 versus an S, do as was suggested a few minutes ago, evaluate more where mom is at. Like, this is an area for further exploration, as you're saying too, Michael. So you might want to, Anna's 8, you might want to divide your 1.5 hour slot if you have the potential to do that. I would recommend that, especially in the beginning, but typically with complex trauma, we do need an 1.5 hours if we have a caretaker involved, so that the child is with you individually for 45 minutes to an hour, depending on their tolerance level, and the caretaker is with you as well for 45 minutes to an hour. In terms of assessment and understanding capacity and potential and trauma history, we're not acting as the individual therapist with the caretaker, but we also want to develop and facilitate a therapeutic relationship with them. Concurrently, it may be the case that this caretaker really is more amenable to being in a group with other caretakers. And when we conducted groups like that, which were concurrent with collateral sessions and with individual therapy with their child or children, we also began with an assessment phase whereby we use the trauma symptom inventory, the TSI-2, with adult clients. Again, there are other tools that you might use because I have to make full disclosure here that my long-term partner, John Briere, created these measures. So I cannot say, that you should use this measure over another, but it is an example of how you might be able to assess the extent to which a caretaker is traumatized in this other context, in a group context. And we also use self-portraits. We also had caregivers describing what their treatment goals would be for this 12-week group. So other modalities, in addition to the individual collateral sessions, can be helpful. Also, observing the caretaker with the child in session is going to give you more information. And through these ways, then, and maybe having, which I've done before, having the child and the caretaker do a family drawing, do a drawing of, create a drawing of the family doing something together, or as a photograph, which can be very revealing. And an example of that was I had an 11-year-old do a drawing depicting the family relationships as she saw them, and then her mother doing the same thing in the same session. The mother drew a house with God shining down, and they're all reunited in the house, including the alleged perpetrator who sexually abused my client, whereas the child's depiction had individual portraits, neck up, only the face, enclosed in frames for herself, her mom, and her sister, excluding the alleged perpetrator. So that gave me information about, the mom's capacity, the child's capacity, and so forth. And I could talk a lot about other cases where drawings, genograms, and actually, as I talk more about caretaker and family interventions, I'll speak more to the notion of how you can evaluate even as time goes on, not only in the initial phase. So great comment. The notion is, it's not carved in stone. This is a tool that you can use in supervision, in your collegial meetings, case meetings where you're discussing a case and you're saying, boy, I'm really wondering about this area. What do you guys think? Would you consider this a 4? Would you consider this a 1, that it doesn't need to be addressed right now? I think we're all in agreement that with an 8-year-old with suggestions of attachment insecurity, the caretaker support needs to be identified in some way as a priority. But it may be the case that you as a therapist can't make it a priority, or attachment insecurity can't be a 4 right now, even though clinically it makes sense that it's a 4, but it's not an area to target, if this makes sense, until you have greater safety. So it's really a tool that's meant to promote discussion around these issues. I can take one more question if we have it, and then we'll have to move on to the interventions. And you'll have time at the end to talk more about this. Did anyone else have their hand up? I can't really see. Sadie, is there anyone else?
I think everyone is good now.
Okay, let's move on then. Okay. So with the ATF-C, what you're looking at in terms of thinking about the possible interview questions, for example, the possible interview questions, and I'm trying to get rid of, there we go. Let's see if we can get rid of the chat box. Well, looking at attachment insecurity with possible interview question topics, trust of people in general. We want to think about that for Anna. Worry that caretakers will leave, abandon him or her. Friends in their social network, need to keep parents or other attachment figures at an emotional distance. So those would be specific questions that you would use. Okay, there we go. Those would be specific questions that would help you to assess then to which, say, attachment insecurity should be scored as a 4. And so some of these have been mentioned already. Anna's treatment priorities using the ATF-C. Safety was certainly mentioned, caretaker support issues, anxiety, post-traumatic stress, attachment insecurity, depression, low self-esteem. What are the potential cultural factors as well, always embedded in our assessment? Now, just looking at this particular slide, we have 7 different areas that potentially could be target areas for treatment. What your task is going to be is to narrow this down at the intake stage so that, you know, simultaneously you can use interventions focused on safety, you can use interventions focused on caretaker support, and certainly depression, because that also overlaps with safety and might involve suicidality for Anna. You just don't want to have, you know, a plethora of 4s, because then it becomes sort of a jumble of interventions. But you can, within one session, address safety issues, address attachment insecurity. And how do we do this? Well, I'll show you in a minute. Okay, so starting with, again, matching up the ATF with the PIQT, with the 5 questions for each problem area. Then we have the problems to components grid, child version. So for a problem area, say caretaker support is identified as a 4, and therefore you want to look at the treatment interventions that are commensurate with that problem area. You would look at chapter 15, interventions with caretakers, family therapy. If you're looking at safety environmental issues, then all of these chapters that are listed are ones that would help you to think about the interventions you might use, again, over a period of time, right? And you're also updating and reevaluating by using the ATF at those 3-month intervals. With shorter term treatment situations, you might actually be using it more often than at 3-month intervals. So problems from the ATF-C that may be assigned highest ratings, 3s and 4s, and have been mentioned, post-traumatic stress, safety, the therapeutic relationship, so that Anna feels safer within the therapy session to be able to do the trauma processing work she needs to do, and to be able to gain more affect regulation capacity so that she's not feeling as depressed and she's perhaps not as reactive in situations or as triggered. Caretaker support was also mentioned and could be categorized as a 3 or 4. So then the treatment components from the PCG-C would include play and expressive art therapy to address and facilitate those areas identified on the ATF. So including therapeutic relationship, distress reduction, affect regulation training, emotional processing, cognitive processing, psychoeducation, relational attachment processing, trigger identification. So these are all intervention areas that might be included in your treatment planning. But again, the work is flexible. You're mindful of the components of ITCT, and using the assessment tools and the other tools that I'm mentioning, as well as your own observations, your own clinical experience, consultation with colleagues, and so forth, so that you're able to really ascertain how to combine treatment interventions, how and when to address caretaker support issues, some of the things that have already been discussed. So beginning with the client-therapist relationship as the active ingredient, not only is safety a priority early on, but throughout therapy when we're intervening with complex trauma situations, but the therapeutic relationship is the context for the child to integrate traumatic experience, improve perceptions of self and others. The internal working model, as Bowlby defined it, so that they feel a secure base even within the therapeutic relationship situation, you're an adult, you may be particularly evocative because, say, your cultural background and gender are the same as the person that hurt your child client, and therefore you, by just virtue of your stimulus value, you're triggering for that child a high level of distress. So from the very beginning, we want to talk about what it feels like for them to be seeing you, say in my case, a white middle class, cisgender female, having that conversation from the very beginning, so that not only are you creating a safe environment and a safe space for very difficult conversations and very difficult processing and expressive work, but you are also facilitating the development of a therapeutic relationship, which hopefully is going to feel like a secure attachment relationship. Not that you're taking your clients home with you, but they have a place to practice attachment seeking behaviors that they can then generalize to other situations where they might feel safe. And therefore, they're also gaining greater self-capacities. So through your mirroring, even if it's, going under the furniture because that's where they're retreating in their high level of distress, you're right there with them. You're empathically attuned to the pace that they need to go through their trauma experiences, processing their feelings, providing choices of play and expressive therapy activities. And an important piece of this is, sometimes in some treatment models, they recommend or advocate or even require that you only are concerned with the trauma exposure that the child is presenting with. With this model, we are more flexible than that. It may be the case that a child initially is talking, say Anna is initially talking about sexual abuse by the uncle and not able to really talk about her attachment insecurity with her mom until later down the road. Or maybe she can talk about the traumatic loss of her grandmother, but she can't really talk about the sexual abuse. Again, it's more that instead of the medical model approach, doctor-patient, it's more, and this may sound funny to you, but it's more of a personal trainer-client relationship where we try to reduce the extent to which there's a power differential. However, we're providing structure, we're providing boundaries, we're monitoring our own activation, we're mirroring, we're providing choices, as I mentioned, we're inviting kids to explore the therapy space and really check out what is available for them. But we're also providing some guidance. And as I said earlier, we're not just sitting back, not asking questions. No, we're providing direct inquiry because we know that kids are going to have difficult in many situations, most instances, are going to have difficulty spontaneously reporting their experiences. So the more that we can structure while also providing choices, while also being mindful of their capacity, then that is going to strengthen the therapeutic relationship and allow for more trauma processing work. The therapist uses humor and playfulness. I'm all about taking the situation seriously, taking the child's needs, feelings, resources, capacities seriously, but also having fun within the session. Maintaining a safe and predictable therapeutic environment. There may be chaos while the child is engaging in trauma processing work, feeling very dysregulated. You're helping them to regulate that affect, but you're also ending the session in a quiet manner, in a safe, calm manner. They return the toys to the shelves, everything is put back in a predictable fashion. It's like I used to say, you know, in all the years that I was seeing kids and doing my own work with kids in therapy and supervising, that I couldn't change my hairstyle for years. And when I had orthodontics as an adult, oh my goodness, that caused such consternation for my clients. It was like, oh, you can't change your hair. Oh, you've got braces and you're 40 years old, you know, what the heck? So, you know, as much as we can, I'm not saying you wear the same clothes every time you see that particular child, but make sure that the environment is safe, predictable. The toys are, you know, neatly placed. But while they're engaging in processing, you know, you're not worrying about things being broken, but you're reminding them that we keep things safe, we don't throw things. And I've had Lego pieces thrown at me and, you know, all sorts of things over the years, but you really reinforce those boundaries, which then engender safety within the space. Obviously, you're not going to interrupt the session with a phone call or looking at your text or answering the door unless it's an emergency and there's an earthquake. You know, you really maintain that safe place, and you're really conveying over and over and over again consistency and that empathic attunement, non-judgmental, non-authoritarian manner. And this also is connected to how you work with caretakers. Okay, so little humor thrown into the presentation. No, we did not torture the dog on the right with the witch's outfit. She actually loved to wear that for Halloween. And the comment, the title, "You Get Paid to Do This," was actually said by one of my kiddo clients who, in the midst of doing very active play and trauma processing, said to me, "You get paid to do this?" And he was really quite shocked and amazed. And I said, yes, isn't it wonderful? And you too could get paid to do this. You could become a therapist when you grow up. So, you know, having fun, having humor. There are lots of examples that I've given in my writing of this. Okay. Resource guide, a few more tools for your toolbox, your toolkit. The NCTSN Youth Resource Guide was a guide that the Complex Trauma Work Group of the NCTSN, I was involved in this, created a guide that can be used with kids, that can be used to for psychoeducation around what complex trauma looks like. I've given you the link here, but it's also available at the website. Other examples, and there's a more complete list given not only in the ITCT-C book, but other articles and chapters that we've written. It's Perfectly Normal is a wonderful book that I've used in sessions, including family sessions with a child and a caretaker, where we look at various topics that are handled there. You may be familiar with it. Moody Cow Meditates and other books around self-esteem, mindfulness, also really useful. That's the cover of what is complex trauma, giving you some examples of the difference between normal life, bad things, the ups and downs of life, to PTSD being a big cloud, to complex trauma being a lot of different clouds. Again, not pathologizing what kids are dealing with, but helping them to understand better. Some other examples of books, games, play to assess and treat trauma exposure and related feelings. I'm all about having tools, and no doubt you have come up with some of your own. Chandra Goshipan has done a whole series of books published through Piplo Productions, but one example is Once I Was Very, Very Scared. Lots of tools that can be used with younger children in particular, and in conjunction perhaps with family therapy sessions involving caretakers. And the oak cards I've mentioned, sand tray, if you have access to one, a pre-doc intern who is one of a group of interns at USC in the outpatient clinic when I was there back in the 80s, believe it or not. He was one of those folks who was having difficulty with the play therapy approach with younger kids, and he was really struggling with it and was much more comfortable just sitting and verbally talking with kids. And I was really trying to encourage him to use play therapy interventions. Well, lo and behold, he came in one Monday with a sand tray that he had made according to the specifications, provided in play therapy materials, and did a demonstration with the one-way mirror with a team of us with his child client. And it was really a wonderful transformation. He really embraced play therapy as time went on. Here's another example, though, of a simple art activity to help a child identify feelings so that they construct. It could be, a gingerbread figure, neutral figure, or could just be a circle, as was used with this child, and then coloring in the different feelings, again, reinforcing the notion that you can have a lot of different feelings simultaneously. A book that I've used a lot in play therapy, Double Dip Feelings, provides wonderful scenarios of situations where a child, say, is upset but happy at the same time. One example, I think, was a child who didn't really like their dinner and puts their food, when mom isn't looking, into the dog's dish, and feels happy that she doesn't have to eat the food, but then feels sad because her mom doesn't like this and, says, no, you really can't do that. And, Chico is allergic to chicken, so can't eat that chicken. And so the idea of having a lot of different feelings simultaneously, this is the human condition, and we really need to help children to be able to do that for themselves, to identify and express those feelings while they are also processing trauma. So again, if a child is super activated or they're so dysregulated that even talking about, another example is a child who had multiple traumas. Her family was homeless. Then her mother had some psychotic process going on, and basically relinquished control of the kids. So they had the experience of being homeless and in unsafe situations, and then they lost their mom, essentially. So it was my client and her sibling. And she were in foster homes, and then the sibling was adopted and she wasn't. So she had multiple traumatic exposures. Then it turned out that one of the boyfriends of the mom had also tried to drown her. So there were many exposures that did not all, they were not all disclosed. They were not all revealed in the beginning. And in fact, this was a child who would crawl up the stairs to my office, making animal noises, hiding under the furniture, truly dysregulated, truly not able to process trauma without feeling such a level of distress that her behavior was so regressed. So we had to do a lot of relaxation exercises with her, breath training, grounding, we're in a safe place, you're not being hurt right now. Also doing neutral play can help in terms of, this might be a child that needs to do some physical exercise. If you have access to an outdoor area, we had a porch on the back of the house at Stewart House, and kids would go out there. At USC, we had a whole outdoor area with gym equipment and a basketball net, whatever you have on hand that can facilitate that calming, bringing to, or you're just in the room and you're practicing breath training, or as some kids say, belly training, where they're sitting, they hold, say, a stuffed animal on their tummy, and they can feel, their breath as the stuffed animal rises. I wouldn't encourage having a child lying down with their eyes closed if they have a sexual abuse history. That's going to be too triggering, too evocative. So you use your clinical judgment in these situations, and probably not using the word meditation with a 5-year-old, but you might go through the book Moody Cow Meditates, and Grandpa in that story tells Moody Cow, who is having problems regulating his affect, about a jar with sparkles in it. And when the jar is shaken, then that's like the feelings that they have that are being tossed about and in turmoil. And then when the sparkles settle, that's when you're feeling calm and you're able to talk about your experience. So when a child is highly dysregulated, that probably isn't the time to do trauma processing work, even in that moment. But helping them to bring down the distress in these ways that I've mentioned, so that they feel calm, they feel a sense of self-efficacy, and then they can do some of the trauma processing work. So the example of the play therapy session that I mentioned, in longer trainings, I'm able to show the film and then we talk about it. There's a part 1 and a part 2. The part 1 is the enactment of a child who is highly distressed and what the therapist does. And then part 2 is the child and the therapist talk about what they found helpful, or in the therapist's case, why she took the direction that she did. And that is an example of how a tool like Moody Cow Meditates can be used in therapy. So the emotional regulation capacity is also an area for assessment. Is the child able to and express feelings? How might they identify when they're triggered? Say you're in the middle of a session and a child is very triggered and dysregulated. It may be that they're not saying, oh, I really felt triggered right then. No, they might space out. They might not hear what you're saying and then say, what did you say? Or, I really have to go to the bathroom right now. Or, I have a really bad stomach ache, Dr. Cheryl, whatever. It's going to be the case with younger kids that it's going to be more behavioral and less verbal, but they may also be able to enact through role plays with dolls, the dollhouse, puppets, etc., situations where they feel triggered. So the ITCT-C approach to the trigger grid is a little bit different than the adolescent version, but basically is helping the child to identify situations. First of all, what their understanding is of a trigger, like if they hear a car backfiring, that reminds them of the shooting that they witnessed in their neighborhood. Whatever example is going to be authentic and relevant for that child, to help them to understand situations when they feel triggered, and to help them to delay, say, in a sexual reactivity kind of situation, it's likely that the child was feeling anxious. Say they're compulsively masturbating when they're feeling anxious, and they're doing this in the classroom, and the teacher and the students are having a problem with it. So it's got to be addressed in a non-judgmental way. But it's going to be the case that you're going to help that child understand how they were feeling prior to needing to self-stimulate in that way. And we're also going to be providing education to the caretakers to that foster parent around affect regulation issues and tension reduction behaviors. This is what I mentioned earlier about the emotional intensity in the ITCT-C session. So obviously, you're going to start off with neutral play, checking in, how's the child doing, then gradually moving into more intense material. For some kids, it may not look so much like a normal bell curve distribution, but more like a narrow blip, right, of trauma processing work. But as time goes on, that period of time is going to become longer, hopefully, so that they can do more of that work in their safe space with you. Cognitive emotional trauma processing. I know in the interest of time, I need to move along because we want to get to the family and caretaker area. We're helping the child to reconsider their beliefs. A 5-year-old who's adamant that they could have stopped Uncle Joe from touching their pee-pee because they could have punched them out. They could have used karate. You're not saying, oh no, come on. You're not confronting it. You're encouraging the child to really explore, well, how tall are you? And do you know how many pounds you weigh, versus Uncle Joe? So in that way, you're helping kids to kind of revisit those beliefs that may be contributing to a sense of shame and a sense of, I should have stopped the abuse. Whereas, we want them to understand how they can go to safe people, to, if they ever feel unsafe again, who can they go to as helpers? Who are the helpers in their lives? And creating that coherent narrative through Sandtray work, through the titrated exposure of being gradual at the child's pace, always very child-centered, with supportive caretaker, using doll puppet play, Sandtray, collages, storytelling, role plays, and so forth. Now, relational processing in ITCT involves this phenomenon of you are within the safety of the therapy room and the therapeutic relationship. You are encouraging in a gradual manner and according to affect regulation capacity, exposure work. So the child is enacting a situation or telling you or drawing about a situation or creating a collage, but as well as describing the traumatic experience, they're also expressing the feelings, what they're feeling right now in the moment as they're acting out the situation and how they felt when they were being traumatized. So in that way, you have exposure, you have activation of the feelings that are manageable. You might be able to, move that therapeutic space, or as we refer to it, the therapeutic window, wider so that they can do more trauma processing work. As time goes on, you're working with the caretaker or the family system so that there's more support at home, etc. So through that process, then the child is experiencing disparity. So there's safety. There are rules and guidelines around enforcing safe play. The therapist is providing empathic attunement and support and not hurting them. So it's not only that they're safe and they're not being hurt, but then the counter conditioning piece is where their activated distress is paired with positive feelings. So that's where the secure attachment comes into play and how they can feel a greater relationship to the therapist and greater trust as time goes on, which is possible, or more possible, shall we say, with longer term therapy. And then eventually there's desensitization, so the traumatic memories become memories. And this process is throughout ITCT, whether we're talking about the younger kids or with adolescents. And relational attachment processing also, as I mentioned, is more likely to occur when the treatment is longer than 12 weeks, which is the duration for many other EBTs, we have the opportunity to do more of this work with the primary caretakers and addressing those implicit memories that are manifested through triggered behaviors. This is just a quick summary of the different attachment styles, going from secure attachment, where there's a secure base, the parenting style is empathically attuned consistently, to avoidant, where a parent may be dismissive, avoidant, rejecting the child is very dismissive with you in the therapy session, or a child may have one dismissive avoidant caretaker and another caretaker, say in Anna's situation, perhaps the relationship with the grandmother was very secure and she was very empathically attuned, but the mom was very dismissive, disengaged, or maybe she was preoccupied and anxious, ambivalent towards her child, uncertain. Maybe that was the nature of the insecure relationship. And then disorganized attachment style is where the child has not experienced any attachment insecurity. The child that I was describing, who had the multiple exposures, the loss of the mom, mom's boyfriend tried to kill her, she was a good example of a child who did not, in those early years, have any attachment security. But then she was in a situation where she was in a foster home and really was receiving empathic attunement, consistent support, and was able to not only establish secure attachment relationships with family members who were caretaking with her, but also within the therapy relationship. Assessment of attachment relationships, as I've mentioned, through drawings, developmental history, and family history. Some of this is repetitious, so I won't belabor the point. Collateral sessions also are opportunities to provide support for the caretakers, psychoeducation, help them to develop more effective parenting skills. And also the work can be in parallel to what we're doing with adolescents around affect regulation and dysregulation, distress reduction, relational processing, the things that I've been talking about. Trauma processing and processing of triggers may be a priority to improve caretaker support of traumatized adolescent. Thinking about Anna, again, that was a situation where potentially her mom would be highly triggered because of her own trauma history by Anna's behavior. And as was mentioned, you know, the very notion of Anna's getting help, whereas I did not get help, and resentment around that, that can trigger reactions with the caretaker. So we really want to have an opportunity to address those issues. And it may be the case that the caretaker really requires their own individual therapy, and that may be offered or provided in another agency. In our agency in Long Beach, we were able, because we had such an array of therapists, interns, postdocs, licensed folks, we had, you know, the whole range, master's level, doctoral level, and these clinicians then could share cases whereby one particular therapist might be working more individually with a caretaker if that was really warranted and the child was young or there were multiple victims in the family. So you might have a situation where there are 3 kids in the family who all need an individual therapist. The caretaker needs their own therapist. And then it gets really interesting when you start doing family work, because all the members of the family who also have their own therapist present are attending the therapy session. And to me, it's like the more the merrier, you know, if it's appropriate, obviously, and caretakers are amenable to these other modalities. But again, when children are dependent on those caretakers to keep them safe, then it behooves us, and it really is an ethical requirement that we intervene in some way with those caretakers, with family members who are having contact with the child. And it may be through parenting classes. That may be the foot in the door, that then leads to other interventions. It may be that you're involving other outside agencies. This slide just shows you an example of 6 sessions that might be considered for family therapy, starting with assessment, always beginning with assessment of family functioning. And this is where, you determine that the child is going to be able to manage what comes up in the family sessions. The caretaker is amenable. There may be other extended family members who you deem appropriate to participate. And through this, again, you're dealing with intense material, but you're enjoying being together. You're doing role plays that really can inject humor into difficult situations. Say the child is role playing mom and mom is role playing the child with a particular stressful situation that arose during the week. So there's a lot more that I could say about caretakers, work with caretakers and family therapy. So in a nutshell, we're providing with ITCT-C individual therapy for the child client, usually weekly sessions, typically also that are individual or dyadic, meaning, 2 caregivers, say 2 parents, or mom and a grandmother, grandfather and grandmother, or the child and the caretaker. So you're also whatever is deemed appropriate for that particular case, as well as doing family therapy, usually not immediately, at least 6 sessions if possible, but they may be, depending on your resources, it may be that they're bi-weekly, and you meet the preconditions of safety, affect regulation, and relational capacities. You determine the extent to which it's going to be possible because the resources are there. The caretaker is able to be present, to be empathically attuned, but also considering the fact that they may not be as supportive as the child really needs, but they're open to considering how they might develop more skills. Individual therapy, as I mentioned, for the caretaker, and group therapy is also described in the various resources. So just quickly, this is Jamal. I know we're almost out of time, so I'll just say very quickly, Jamal is a case where you're going to be considering a number of different modalities. This might also be a case that we could include in our Q&A, but he's an 11-year-old African-American boy referred for depression and reported abuse and neglect. He lives with mom and sister. Stepfather, who no longer lives with the family, quote unquote, beat me lots of times, and sometimes my mom too. He said I was stupid and no good. Mother works at 2 jobs and is seldom home. Mother states that Jamal is out of control and may need to be placed in a foster home. Jamal was suspended due to an aggressive incident with another student swearing at a teacher. He expresses suicidal ideation and has started to smoke marijuana. Jamal has a 16-year-old sister who reported sexual abuse by an uncle 2 years before. So we've got lots going on with Jamal, and I do want a few minutes to talk about self-care. That slide just reminded me. But in this situation, you're going to be thinking about timing of interventions. You're going to be thinking about how do I use the assessment treatment flow chart. Mom is, she's clearly overwhelmed and has probably her own, she does have her own trauma history. And, so it's multi-generational. We also have safety issues that need to be addressed. And what about the sister? Has she engaged in any therapy subsequent to reporting sexual abuse? So a lot of different modalities. If we had more time, we could spend a day talking about Jamal and his situation and how to prioritize. But I also want to include a little bit on self-care strategies. This is really integral to this work, that it's really important that we understand our own trauma histories, because inevitably we all have come into this work because of our own losses or acts of commission, omission that we experienced growing up, attachment, insecurity. Hopefully we've had therapy along the way, or good training, good supervision as well, that has helped us to be self-compassionate about our own reactions, using tools like Regain, which I may have time to talk about in part 2, but this is the reference, Briere 2019, in his book on self-injurious behavior. Regain meaning you recognize the feeling, you're grounded while you're experiencing it with acceptance. You explore or investigate, and then you non-identify with the feeling, or you let it go. Having a balance between work, clients, vacation, collegial support, personal therapy, retreats, spirituality, exercise, family and friends, creative pursuits. I've written a novel and I'm working on another one in my spare time. I like to cook, I like to garden, I like to travel. It's important that you have a life outside of the work. And as I mentioned, humor, being playful with yourself, with your clients, having fun, increasing fun and joy in your life, so that you are able to be present and available to your clients. Balancing, the extent to which you have very challenging clients versus clients who have more emotional resources. That kind of balance is really important. And in the various clinics that I directed, my door was always open for therapists to drop by to share instances that they were encountering that were challenging, unless I was involved in a meeting or seeing my own clients. So having that kind of support is really, really important. And I know during the pandemic, and I should mention, at the ITCT-C USC website, we have a teletherapy guide as well as other guides that we designed to meet the needs during the pandemic. And just a few photos to remind us of fun and being with children and pets, going to places. This is Belize, by the way. I would highly recommend Belize. And this is the South Bay, but I'm sure you all have beautiful places that you visit and spend time, centering yourself and using your own mindfulness to take care of yourself and using self-compassion. You have references that include a lot of the materials that I've mentioned, some of the resources, including conferences such as American Professional Society on Abuse of Children. I need to throw in a plug that I would encourage you to become a member for the California chapter if you're not already, as well as the national organization, and attending their conferences that they hold on an annual basis. Also, the International Society on Traumatic Stress Studies they also hold annual conferences, great sources for materials, webinars for ITCT-A, etc. I will talk about next time. We also have monthly video consultation calls that people can attend after they have had their first 6 hours of ITCT-A training. You don't need to have or meet that requirement to attend the brown bag seminars, and I believe the notice has been distributed for this coming Wednesday. So in 2 days we have a brown bag seminar, and I believe that's it. And we have 6 minutes for questions. So
I see
let me
Michelle-
go. Yeah.
Michelle was asking if there are YouTubes where you, or other videos where you demonstrate some of these tools in sessions, like using the Moody Cow book.
The Moody Cal Meditates demonstration is already available at the NCTSN Learning Center. So also when I do more extended trainings, and if that is something that people are interested in for their agency, I can provide, 6 hours of training where we have more use of demonstrations and discussion of actual case materials. Today was meant to be an overview, but definitely if you have that interest, whether it's ITCT-C training or ITCT-A, contact Don, or also look at the website, the ATTCUSC.edu website. We have webinars that are available there that can be accessed free of charge, as is the Learning Center, NCTSN. I'm not doing additional YouTube videos because I just don't have time for that. But I am, through these trainings and through the materials that are already available, people can access those demonstrations. I should also mention that at the Learning Center, in addition to the video showing how Moody Cal Meditates was being used, there are other demonstrations. I didn't mention it so much today because most of them focus on adolescents who have complex trauma, critical moments where complex trauma or developmental trauma, through the University of Connecticut's center, where a number of us therapists did these role plays with actors depicting certain critical moments. So lots of materials out there that you can access that go well beyond what I am able to do. Should people be unmuted for the last few minutes? I can try to go through the chat box, but also if you want to put up your hand maybe to be unmuted. Yeah. We had more comments about Anna, lots of comments about Anna. That's good. And yeah, using the comment, I wonder what, that's really helpful to open up trauma processing work. How many times have you been in situations where kids are really reticent? Maybe they're not so dysregulated that they're not able to do trauma processing work. They're just really withdrawn, and they haven't really had an opportunity to feel validated. No one has really checked in about their feelings. So they don't even have the words to be able to verbalize or to enact. They're holding back. They're more detached from you. Using opening questions like, I wonder what it might feel like if da 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 da, or having them draw just what they're feeling right now. And if they're not able to do that, well, draw yourself in a situation that you can think of where you were upset. So you're bringing in material that isn't specifically directly related to the traumatic experience per se, but it's opening up processing of feelings. It's emotional processing that goes hand in hand with helping them to have grounding skills, breath training, and so forth that can bring down the distress.
I do want to take a moment here really quickly to let everybody know that we are going to change the type of Zoom meeting for next time to allow for the breakout sections and for everybody to see each other. There was a little bit of a technical glitch this time, but next time I promise, when we meet on March 22nd at 9 a.m., we will have the ability to do that. So it'll be a little more interactive next time we meet.
And I appreciate, that despite those challenges, we were able to get, comments in the chat box, and some folks were able to put up their hand and, contribute. So it's always the case that, you know, when you're talking about interventions for such complex situations that, you know, you may go away thinking, well, you know, I really wanted to know more about this particular area. So I would invite you to explore the other references that have been provided, as well as these other webinars and materials that are available, as well as checking the website to see, you know, where there might be upcoming trainings that you could attend. Most of these are, you know, provided free of charge, and I do virtual trainings for groups across the country that you might be able to join, as well as in-person trainings more and more as time goes on, and we're, you know, free of the COVID debacle as much as possible. You know, things are opening up a little bit more, and because I do understand that when we do trainings virtually, you know, it's not quite the same as being in the same room. And you know, I love doing these trainings, but I really enjoy having interactions where you are able to really discuss cases together. So if we have an opportunity to do that somewhat in the next training, that'll be wonderful.
Yes, and I'll also mention to the CVCA members that we are already talking about next year moving to some in-person trainings, because we miss you all as well. So something to look forward to.
Great. Thanks, everyone. Thank you for being here today, and thank you for doing this really important work. Be well.
Yes. Thank you
Thank
for
you.
joining us. I will be sending up follow-up material. Have a wonderful day, guys.